So Chadda sir has been a mentor to all of us, and he is a consultant endocrinologist at PD Hinduja Hospital, Mumbai, Hope Care Center, Navi Mumbai. He has a huge teaching experience. He's been teachers to most of the endocrinologists in Maharashtra. He's trained in use of artificial pancreas at University of Ulm, Germany, and he's been the past president Endocrine Society of India, past president of Indian Society of Bone Mineral Research, a member of the Asia Pacific Regional Committee of IOF, and numerous publications and chapters to his credit. So he's going to tell us on how to break the cycle of obesity management to protect bone, joints, immunity, and the data available for treatment of obesity.
Thank you, Vaishali. Thank you, the Sphere team, for inviting me for this talk. Actually, I was looking at your program. Unfortunately, I'm attending it for just the first day. But the earlier days, you've covered up a lot of things on obesity. And today morning, I attended some sessions on strengthening of the back and the bones. And I missed Sachin's talk, but I guess he was talking about preserving muscle and bone also. Uh, so let me confess, my primary interest is bone and not obesity. But now I find in the last 3 or 4 weeks, I have taken a talk on obesity and muscle. I have taken multiple talks on obesity and bone. But last Sunday, I talk on obesity and the vascular system. I mean, for me, that was a googly. But then I learned, while I was preparing, that obesity, bone, heart, and back to obesity. So they're all connected. So I think yesterday night, evening, I was in a program, and one of these American professors said 240 disease and still counting related to obesity. And a question that he put up is, which organ system is not affected by obesity? Can someone think of it? Yeah. So one student in his class answered I. So there is, and he said, yeah, that sounds interesting. But then he said, no. Because eye, obesity, glaucoma, early cataracts. So it's not that eye is not affected, it is affected. So I'm going to take you quickly. I mean, you people have either have enough information or what I'm going to show you may not interest you. So in the next 15, 18 minutes, basically we've been talking about the components of obesity. And now we understand that it's a proper disease. All these years, अच्छा नहीं लगता, बहुत मोटा दिखता है. No one really looked at the inner problem, which last few years now we have understood. ABCD it's called, adiposity based chronic disease. And at the same time, like I said, the bone, the muscle are a very integral part of the system. One, obesity by self affects bone and muscle. And two, when you start treating obesity, the bone and muscle also get affected. So like my boss used to say, I wish there was a anabolic steroid without androgenic effect. So similarly, we wish we had some weight loss therapies in which the muscle and bone were not affected. I know we are going towards it, but at the end of the day, someone loses weight is going to lose muscle and bone, maybe more, maybe less. Today morning, while we were having our deliberations on the first floor, there was some talk about healthy obesity and morbid obesity. And then, so there is something like healthy weight loss and unhealthy weight loss. Someone comes and says, in the last 2 months, I've lost 15 kilos. I don't congratulate them. I said, no, you've not done a good job. Again, I realized as I'm getting older, I keep talking about old things. And a pound a week is what is called as healthy weight loss. So someone loses 2.5, maybe 3 kilos a month, that is reasonable. Anything more than that would be counted as unreasonable, unless you are someone who has heart problem or a kidney problem, because the initial weight loss is water weight loss. Our body is 65% water. So when you have some patients coming and saying, "Sir, I've done exceedingly well in the last 6 weeks," it's because they've been losing water. That continuous exceedingly well is not going to continue. So encourage uh, patients, or now the term is persons. Don't use the word patient because politically that's not correct. So it's not only what we are doing, but we need to be talking also the right thing so that no one gets upset about it. So it's not obesity, it is person who is obese. It's not diabetic, it is person with diabetes. The person still remains normal. It's the problem that is needs to be tackled. So we say there is a crosstalk between organs. Um, Good old days, it used to be the heart and the kidney. It used to be the kidney and the liver. And like I said, for me, it's the bone which comes very interesting. So the bone and the kidney and the gut, very important crosstalk. And it goes on and on. So here again, between the adipose tissue, the bone, the muscle, the immune system, the psychology, the neural system, all are connected. I mean, whether you connect it directly or indirectly, but it's very difficult to break this into silos. So the fact remains, when you are losing fat, there is going to be some amount of fat muscle loss also. And the muscle is the one which pulls the bone and keeps it healthy. So whether we talk of gravity or whether we are talking in terms of strengthening exercise, the bottom line is muscle decides bone health, and if you want to extend it, muscle decides your health and life also. So longevity also is connected with muscle. So if you're looking at sarcopenic individuals, or if you're looking at individuals who are rapidly losing muscle, in a way you're also looking at their longevity. I mean, I'm not talking about rank ligands to this audience. They have not been done, but these are, I mean, you keep talking about communication. So these are again agents which communicate between the bone and the muscle. And as I said, the strain that we put on our bones and muscles is what keep them going. And morning I attended a session partly where you were talking about fascia and back and things like that. Yeah, so sitting long time is probably today worse than smoking. It's worse than smoking. So every 30 minutes, if nothing else, at least sit up and stand and sit up and stand 5 or 6 times, and you've done something good for your body. Don't look at the formula part, but the fact is continuous stationary posture. Uh, it reduces a protective agent called OPG. So OPG is produced by one of the one of the bone cells called osteoblasts, and osteoblasts produce OPG, and OPG keeps the rank ligand under control, and the rank ligand is the one which stimulates osteoclast. So I'm not gone into the bone cell, but since I've used these terms, let me tell you that the bone cells have three cells: osteoblasts, which are bone formation; osteoclasts, which resorb, eat up the bone. But that's very important because unless a defect is corrected, the defect has to be cleaned up. The osteoblasts come and cement it, and then for years we were taught that osteocytes are resting cells, and later on, when needed, they'll become active again. But no, actually, osteocytes are the nerve cells of the bone. They are the ones which sense the strain and the pressure and the activity or the inactivity. Because osteocytes then produce a couple of agents. Let me see if I have that photograph. Yeah, I'll come to the osteocytes in a minute. So, just to tell you that today the flavor of the season when it comes to therapy is GLP-1, GIP, and maybe next year, you've heard about amylin and weight loss. So, amylin came in about 2 decades ago for diabetes and type 1, and it had to be given twice a day, so it never became successful. It just went out. But scientists, researchers don't lose their desire to do something good about it. So, amylin is going to come back next year, as a part of GLP-1, GIP, amylin for weight loss. And there, amylin is not working on pancreas, it is working on the bone. So each one of these, there are receptors on the bones and they help protect. So now this may sound little strange. I'm saying GLP-1, GIP is protective. And then at the other time, we are saying when we give these agents, there is bone loss. That bone loss is because of weight loss and not because of GLP-1 and GIP. They are per se in the lab, they are protective. But when you look at the overall picture of weight loss, then muscle and bone start going down. Uh, don't read too much into it. I was just talking about the osteocytes. So there is something very interesting that the osteocytes do is they make a product called sclerostin. So just like OPG is good, put it in simple words, OPG is good. Rank ligand is not so good because it stimulates the osteoclast. Sclerostin is bad because it keeps the cell in this form, inactive form. The sclerostin works on WNT, Wnt. So if you block sclerostin or there is a disease where sclerostin is absent, the Wnt works and start at the bottom. For any protein to be formed, you need transcription. So in this state, the DNA is not functional, the RNA is not functional, the beta catenin is away from the nucleus. So we have to do something that the beta catenin is freed and comes into the nucleus to bring about production of protein. And that's the sum total of this slide. Don't read much more into it. And to get that whole thing started, you need Wnt, WNT, to come there. So sclerostin is inhibited, Wnt signaling. So the latest molecules in osteoporosis work through this. And that's the beauty of these molecules. Anyway, so the bone formation cycle is a natural part of healing. So if when we use drugs for osteoporosis, we are interfering with nature. And initially it's all good, the bone mass improves, but if it's used continuously beyond a certain period, it becomes harmful because bone is not a hard brittle tissue, it's a hard elastic tissue. So if it becomes brittle, it bends and it breaks. So that is why it's better to have a hard elastic tissue than a hard brittle tissue. So we use these anti-resorptives till certain extent, and then we start weighing the pros and cons. So here again, there are trials which have looked at weight loss and then how the BMD goes down, because that is our gold standard of measure. Taking an X-ray doesn't mean anything, and especially today in the era of digital X-rays, you can make X-rays as white or as black as you want. So don't rely on that part. Uh, Two other terms for those who are not aware of. So X-ray is not good. BMD is not available everywhere. So there are two. So as I said, bone is turning over. So while it is turning over, some waste products, you can call it, are coming out of collagen. So you have a marker which indicates bone resorption. Just remember it as CTX. And you have a marker of bone formation. So remember that as P1NP. And good labs can do it for you. It's a little expensive today, but once doctors keep asking for these tests, hopefully the price will come down. So when we give any therapy for osteoporosis, we are looking at either the formation marker when we give anabolic therapy, or we look at the resorption marker when we give the anti-resorptive therapy. The resorption marker is more useful for us in the long run because books may tell you give it once in 1 week, once in a month, once in 6 months, once in a year. But if you have a resorption marker guiding you, it can tell you the frequency. So there was zoledronic acid which had to be given once a year. Then it became once in 18 months. Now we talk of once in 2 to 3 years depending upon CTX. So it's a useful marker there. 2 or 3 slides, I'll just quickly tell you what happens with weight loss. So semaglutide, we are looking at maybe 12 to 15%, 18% weight loss. But you see, there is a significant muscle loss also that happens. 2.6% bone decline for 15% of that weight loss is also because of muscle. And it's very difficult to separate the two. So even with tirzepatide, when we are talking in terms of 20, 22, 24% weight loss, most of it is fat, but there is a significant muscle loss also. And that's why don't go for the best or the strongest medicine. If you, some of us are going to write it, use what is, you know, enough. You're looking at a target. Everyone doesn't have to lose 20% of their weight. Someone is 140 kilos, they need to lose 25% of the weight. Someone is only 90 kilos and decide to use a GLP-1 analog, then even 10-12% is good enough. I think this we don't need to bother. So I was telling you what is going to happen next year and next month and next 3 years. There are about 150 molecules getting ready, out of which 3 and 4 are nearly ready. Uh, Day before yesterday, someone came and told me, "Sir, I'm using Reta." So I had heard up till now that it is available. It's not been released officially even in the US. But this patient told me, "I am using it." So I asked him, where did he get it from? So there is someone in Goa who gets it from someone in Dubai, but who's producing it, I don't know, because Eli Lilly is not put it in the market yet. But Retatrutide is something we are all very excited about because it causes up to 30% weight loss, number one. And number two, because of that glucagon that is there in it, it protects the muscle and bone to some extent. So what we are talking of 12-15% with semaglutide and tirzepatide, here maybe it will be 6 or 8%. It will be much better. The other thing which is, I don't know if you've heard of cagrilintide, but cagrilintide is again an amylin analog, and this is there in the US market, and it is working as good as the tirzepatide. Uh, I hope every one of you has heard about semaglutide and tirzepatide. You're aware of it? Anyone who's not heard, I can talk to them after this thing. Yeah. So even with the semaglutide cagrilintide combination, good response and to some extent muscle and bone protection. See, I mean, I'm telling you about drugs and muscle, but what is important, I think Sachin must have talked to you, is good protein in your diet. Most Indians, as my friend says, is we are on a renal diet, less protein. So we need good amount of protein. We need good amount of exercise, and unfortunately most of us look at walking as an exercise. That's not enough. You need weight bearing exercise. So it doesn't have to be done every day. I'm very busy, I don't have time, but at least 3 times a week, at least, preferably 5 to 6 times a week. So the weight bearing exercise, whether you do weights, whether you do stretching, whether you do, I like to advise bands because something I find it a little more friendly than weights. So whatever is your preference and your guide, please do that. So osteoarthritis is another component of obesity, and somehow it goes into a different department altogether. It doesn't stay with physicians. But weight loss has multiple benefits when it comes to the joints. And one question that comes up when we use a semaglutide or a tirzepatide is those benefits on joint only because of weight loss? And the answer is no, because these drugs have got anti-inflammatory effects also. And there again, they help this. Okay, so I have got my signal for 18 minutes. So I'm going to summarize it soon. Yeah. There was some discussion about DEXA also. I think Sachin was talking about it when I came in. It's not available freely in our cities. So forget about tier 2 and tier 3 towns. But even in tier 1 cities, you don't have it freely available. But it's nice to get a DEXA not only for bone, but for the body composition. See, everyone likes to have some sort of objective screening. If you don't have DEXA, I'm quite happy with the body composition analysis by bioimpedance, which can be done very easily in most clinics. And try to avoid rapid weight loss triggers. And if there are additional comorbidities, then take care of those along the way. There was some discussion on how often you need to do these investigations. Maybe DEXA is once in 6 months or a year, but the other thing can be done every 3 or 6 months in your own lab or clinics. Yeah, so that's my final slide. That when you have a patient of obesity and you want to get into treatment, it needs a holistic approach. There is no idea looking at a BMI alone. Nowadays, instead of BMI or waist hip ratio, we've started talking about waist height ratio. So if the waist height ratio is more than zero point 0.5, then you know that this person is in trouble. So the waist should be less than 50% of the height. And then we've got other parameters along with that. So that's where bioimpedance also comes into picture. Try to get their nutritional survey, try to look at what they're eating. I encourage a food diary for a couple of days so that we can get an honest sort of impression of what they're doing and where we can modify. Stress on protein intake. Most Indians tend to eat a lot of salt. So that is another big culprit when it comes to the bone. So salt, chili, pickle, papad, whatever can be restricted is good. The mechanical resistance training. So walking, I repeat, is not enough. You need to do some sort of good exercise. And wherever available, bone markers, other biomarkers that are there. So it's not compulsory, but anything which we can quantify makes the patient more aware of what is happening and the response. Like, for example, if I show that the fat is 42% and the muscle is only 12 or 15%, and after 3 4 years 3 4 months I can show that that 42 has become 38, they feel nice about it. So quantification in whatever way is very important. So I'd like to thank you all, Vaishali and the group, and for all of you for listening to me. But obesity is a big problem, and as Dr. Gangadhar was saying in the morning, we need to take small steps, and it is pretty gratifying. I mean, once the patient starts losing weight, and it is not a short-term treatment, because very often after they've lost 10, 12, 15%, the next question is, when can I stop all this? The answer is no, never, because it's a lifestyle change. um, I didn't talk about sleep, but sleep is another very important part of this lifestyle, and it has to be forever. Thank you very much for your patient hearing.
She's a consultant endocrinologist at Sir H.N. Reliance Foundation Hospital. She is a
Have to change
graduate
from
from
here?
PN Medical College and Nair Hospital and believes
your-
in holistic approach to patient care.
Okay, thank you.
She has a clinical expertise and demonstrated a strong leadership in administrative domain. She's held various positions in the Maharashtra Endocrine Society and currently is the vice president elect of the National Endocrine Society. She has been a keen research interest and pioneering research in fasting in Ramadan on diabetes patients, and she was awarded the prestigious Hamadan bin Rashid Al Maktoum Foundation for Educational and Medical Sciences Award for a development of risk stratification score in fasting patients. So over to you, Shaila.
Thanks for those kind words, Vaishali. It's always a pleasure coming over here. It's almost like, a second home. So thanks to Vaishali, Chetan, and the entire team for having me over here. And to be honest, one quick question to the audience before, sir, are you going to time me? I please, because I'm bad at timing myself. So 2 minutes पहले बोल देना ऐसा done. Thank you. So I'm going to basically be asking you one quick question. How many of us really think about when you think about obesity, in the same breath think about could it be an inflammatory disorder? Do we really correlate the two? I mean, really think about, have we overthought about obesity being a disorder where somewhere the entire genesis or, the starting point could be inflammation? Yes, no? Front row is not allowed to answer. So we have one person who says yes, but the rest, I mean, do we think about, or do we still think that it's just a question of, to some extent, definitely lifestyle, but to some extent could be something more? In the next 15 minutes that we talk to each other, we'll try to understand a little more about not only inflammation. Vaishali told me, speak about meta-inflammation. Honestly, I've never given the term meta-inflammation too much of emphasis till I was reading for this talk. to be, because whenever I hear about this anti-inflammatory diet, I always think it's a myth of the social media. I mean, when this suddenly there was a boom with some celebrities losing weight and calling, saying they're on the anti-inflammatory diet. For 3 months, I had to deal with this word daily in my consulting room for at least 10 times. Every patient who came to me said, ma'am, प्लीज वो एंटी इन्फ्लेमेटरी डाइट देना जरूर, वॉट एवर एल्स यू डू और डोंट डू, वो डाइट देके हमको भेजो. So we faced all these situations, but you would be surprised actually. And the reason I'm saying you'd be surprised is because often we do not realize that the initial point of a problem can actually be so different from what we think it is. And when you look at obesity, you would realize that the entire problem starts from something which is as simple as meta-inflammation. And the reason I'm saying meta-inflammation, because you would realize that inflammation, conventionally, when we talk about inflammation, you know what you think about? You think inflammation is all this. You think inflammation is where you have injury, you're going to have acute inflammation, you have an immune defense. That's what our pathology book always taught us. And then there's again back to homeostasis. What you realize when you talk about meta-inflammation, friends, is that this is a problem which is low intensity, persistent, and mind you, this is triggered by nutrient excess. So the trigger for this is completely different from what we conventionally thought. Whenever I think about inflammation, I always think about acute disease, maybe an injury, etc., etc. But when you're talking about meta-inflammation, especially in the background of obesity, you are now talking about a problem which is actually initiated by chronic nutrient excess. And this excess, what it does, it changes your entire physiology of the adipose cell. And when you look at this changed adipose tissue, what you have is something like this. One, you have in a lean person an adipose tissue which mainly has M2 macrophages, which are peacemakers. They're very fond of you, and they do the tissue repair, they do the clearance of the debris. Absolutely everything is hunky-dory to a reasonable extent. But the moment that adipose tissue becomes hypertrophied as a result of excess of energy, what happens is there's recruitment of M1 macrophages. Now, these cause aggressive phagocytosis, they cause collateral tissue damage, and they cause all this TNF alpha interleukin 6, which we conventionally associate with inflammation. To add to that, you have the MCP1, which is again going to recruit your monocytes and aggressively shift this entire predominance, resulting in something which is actually, this is what is happening at the cellular level. A visual picture, I won't go into the fine print, but a vision over here, if we remember this vision, we will never again think about, obesity being just innocuous. We won't think about when that BMI moves from 23 to 25, oh, you're just overweight, maybe you just need to be a little more careful with your lifestyle. Because by then you would start realizing is that the person sitting in front of you is actually dealing with this at the cellular level, is dealing with this kind of inflammation with a release of all these kind of cytokines, which we've already quoted. This is what happens. These are chemoattractants, which result in immune cell infiltration, a lot of apoptosis, and a lot of cytokine release. So what apparently is starting locally is going to then spread systemically. So this problem, which starts with just maybe some amount of excess calories, is the first inflammatory signal. Adipose hypertrophy leading to hypoxia, ER stress, necrosis, and finally, of course, this entire immune recruitment which we just spoke about. So this inflection which occurs is what we need to keep in mind. Because if this inflection is not something which we can to some extent stop, the patient in front of you looks absolutely fine otherwise. The patients, when you are dealing with metabolically normal obesity, you are having a person who otherwise says, ma'am, I'm fine, I'm just overweight or obese. And actually, to be honest, I've just been dragged in because my mom is unhappy with the way I am. Have you heard this often? Right? You hear this, where people are coming to you more because of pressure. Ma'am, I'm okay, I've got no diabetes, I've got no thyroid, that they perceive themselves as to be healthy. Now, it is your duty as a clinician to, in some way, convey, without it becoming an objectional conversation, that look, maybe a little loss of adipocytes, a little loss of the adipose burden is going to be good for you. And that is where communication is going to play a very, very important role. Because when you look at all these molecules, you are looking at molecules which are doing all this at different levels. With the master pathways, you would be surprised. We all the time say saturated fatty acids, yes, they are bad. But what you would also be surprised is that they are actually activating inflammation. So Sujit today said a very, very interesting statement. It's got stuck in my brain somewhere, where he said that, all packed food, and we're saying, yeah, maybe it's junk food. Sujit shut me down very, very categorically. He said, ma'am, it's not junk food, it is junk. And most of those packed food does have a lot of saturated fat. A very, very interesting take-home message. I'm going to take that back home with me, because that was a very impacting message he gave me today morning when he said, ma'am, that's what you need to keep in mind. And when you think about the unsaturated fatty acids, these are the ones who support interleukin 10 production, less pro-inflammatory, and that means quality is also important. A person may not realize also that packet of chips may seem so innocuous to the person, not only chips. To be very honest, when I got down, the first thing Vaishali I did at the airport was buy that chitle ka bhakarwali. After Sujit's telling me no, I was wondering when I went to my room to pack, ab iska kya karu main? I thought, nahi yaar, ye baar kha lete, next time sochenge. So the first thing, that was such a reminder for me now. So when you look at beyond macrophages, this is what, so that's what you're looking at. So now where from here? What starts locally? Finally, everybody is going to hear about it. Every organ of your body. From the last 2 days, you're hearing about, sir just spoke about obesity influencing. The eye also wasn't affected. Sir, teeth? I was just wondering. I was thinking, I didn't have the guts to put up my hand and ask sir, ki teeth chalega kya? Then I thought sir will say no. So, but I was just wondering which organ is, actually not affected by obesity. So you realize that when this inflammation starts, it's going to actually break the insulin signaling. Because what happens is, of course, there's going to be rise in all your inflazomes, and finally that is going to result in a reduction as far as your insulin sensitivity is concerned. It is going to result in increasing insulin resistance, and of course glut flow translocation reduces. So in a nutshell, what you see is this is what happens. Your insulin resistance is going to increase, resulting in this entire process of inflammation, and all this inflammation is finally going to result in a lot of beta cell stress, which is going to convert into autophagy, compromising the islet integrity, and this entire transition which takes place from insulin resistance to diabetes, hypertension, dyslipidemia, metabolic syndrome, you name it and you have it. And you just didn't realize this all started years back just with that inflammation, which was an ongoing process. And that is why obesity and diabetes, friends, is so closely linked. Because what you realize is what starts as this adipose tissue dysfunction as a result of this entire chronic inflammation results in insulin resistance, hyperglycemia, increased TG fat deposition, activates this entire metabolic dysregulation cycle, and this is going to result in all these endpoints that we talk about treating at all points of time. So where are you and me interfering? You and me are interfering over here, right at the bottom of this slide. That's when you and me as medics are doing our jobs. We are not actually doing our jobs over here. Or maybe as a society, we have failed in doing what we ought to do over there. I'm never sure what is the right answer. But the fact remains that in our consulting rooms, we are seeing patients. I see patients after they develop diabetes. The patient comes to me once they're already diagnosed with something. They don't come to me saying, okay, can I prevent this? Except, of course, now at this point of time when they think they need temporary treatment for obesity. And that also the first question they ask me is, ma'am, aap start to karoge, band kab karo? Before the conversation ends also, the question is, ye band kab hoga? So we are all looking for short fixes, not realizing that actually a short fix, I don't think really exists. It's always the long path. And that's the reason why it's important that if we really want to make a difference, we need to make I'm so sorry. We need to make a difference over here. That we need to be able to understand there is always going to be an inflammatory CV risk, and adiposity is not the same, friends. There could be patients with, and the reason why we're talking increasingly about waist circumference is because of the increased risk of visceral adiposity. The reason we talk about metabolic syndrome is again as a result of this. The next time you see that CRP which is elevated, which I just sort of, because I really don't have a very honest answer, I will just brush over it. I mean, is mainly because of the inflammation that patient already has existing. Often I do not know how to interpret that CRP in a patient who otherwise looks healthy in front of me, who may be not having any other comorbidities, but the patient insists, madam, my CRP is high. And I am clinically, because I'm unable to really say much, and if the moment I utter the word inflammation, I know it's going to open up Pandora's box in the next 15 minutes. So there's a lot of really, hesitancy about talking about that number over there. So what can we measure in practice? Maybe we can measure HSCRP, interleukin 6 TNF alpha, NLR S2 series, and of course, final result in a phenotype context, which integrates this all together to be able to give you a therapeutic shift. And when I say a therapeutic shift, we no longer talk only about weight loss. When you talk about weight loss only and don't talk about long-term outcomes with your patient, you don't talk about the cardiovascular, renal, hepatic, metabolic benefit lifestyle plus molecules offer you, you've actually done injustice. Because you've again explained to the patient that you just need to do so much. You've not explained to the patient that this is a lifelong, ongoing process which needs to be sustained at all points of time, because it's only with that is that you'll be able to modify your inflammation when you move from a weight-centric to a risk-centric management program. So can we really do something? I mean, as a medic, do we have something to offer to our patient to reduce this inflammation? Of course, I mean, mind-body medicine stays one of the most important parameters to manage it. So whether you talk about nutrition, we've spoken about exercise, we keep on talking about 6 to 8 hours of sleep, which I'm sure, I mean, except a few, nobody really in this room gets on the best of days, except maybe a weekend. And data shows that a weekend catching up of sleep is not really as good as sleeping daily. Clear-cut data which says that it doesn't mean that if you're sleeping for 10 hours on a weekend and you're sleeping for maybe 4 hours or 5 hours on a weekday, that is good enough for your health. Believe me, it's not good. So the catching up is not really helping any one of us sitting in this room. And of course, reducing your stress, I mean, the HPA activation, etc., is what we need to do as first-line anti-inflammatory measures. Mediterranean diet, we all know about, but what we do not, again, look as, we do not look as diet as actually making a difference to the inflammation. Okay, dietary advice de diya. Up, we talk about protein, we talk about, but how often do you really look at diet as making a difference, a real difference? We don't think of diet as making a real difference to somebody's life, except from some of my patients have these very, very elite dietitians whom they believe is okay. But in routine life, as a clinician, we all underestimate the importance of diet across the board. But I do believe it makes a very big difference. And whether you increase your fiber, unsaturated fat, polyphenols, is all something which is part of the story. Sir just spoke to us, if I was listening to Sir very carefully, Sir did tell us that GLP-1s are anti-inflammatory agents. Sir very, very categorically said that the reason they show benefit on the bone, if you heard him very, very carefully, is not because of the weight loss only. He said they are anti-inflammatory agents. And it is because they are anti-inflammatory agents, these therapies are what are actually targeting this meta-inflammation. Whether you look at your GLP-1 RAs, what they do at this level, when we are saying they reduce MACE, steatosis, and they improve cognition, they are increasingly going to be used in people living with Parkinson's. What you realize is they are actually making a difference over here. They are making a difference in this entire switch that you are seeing, where they are switching you back to your M2-like macrophages. They are helping you with your STAT3 signaling, with your cerebral glucose metabolism, and that's how they are mitigating the entire pathway rather than with only weight loss. What about SGLT2 inhibitors? Again, drugs which have shown great benefit. And again, when you look at these drugs, you would realize that the cardioprotection and renal protection effect which we think, I mean, there's so many mechanisms which we believe it is part of, which we look at, whether we talk about the glucose lowering, whether we talk about all the other pleiotropic mechanisms by which SGLT2 inhibitors act. But how often do you think that these are anti-inflammatory agents and they're actually making a difference? Because this is where they are actually making a difference. That epicardial adipose tissue, the GLP-1 RS also actually improve the cardiac events by reduction of the epicardial adipose tissue. The ectopic tissue is where the action matters. And this is what you are seeing in biochemistry when you realize that this is where it makes a very big difference. So if I put it all together, if I try to understand where would SGLT2 inhibitors work and where would GLP-1 RAs work, this is where they would all intersect with each other. And that's why at this point of time we say, when you really want to make a difference, maybe this is the best combination you should be turning to when you want, because you're not only going to be able to make a difference as far as acute events go, but you're going to be able to make a difference as far as chronic events go. Because you are going to be able to make a difference at the level of the oxidative stress, you're going to be able to make a difference as far as the superoxide is concerned, at the macrophages and MMPS accumulation, and that's what you want at the end of the day. Sir has already spoken about this, so I won't repeat this. We talk about bariatric surgery all the time, and again, should I in my consulting then be saying obesity is an inflammatory disorder? Should I, next time my patient says, I want an anti-inflammatory diet, say, yes, when we treat your obesity, it is going to be anti-inflammatory in nature? Should we as clinicians change the language we use to make it more friendly for the patient? Because the patient actually does come to you with central adiposity, with labs that are reflecting inflammation, with comorbidities and a history. But do we only talk in terms of losing weight, or do we say you need some kind, you are dealing actually with an immune modulating disorder and you need these immune modulators to be able to make a difference? Interesting thought process. A very, very interesting thought process, because that would change the conversation you and me have with our patients. I think somewhere the reason we don't connect, because no, you're just overweight, yeah, you're obese. How often do we really, say, okay, you're dealing with this and you need to actually make a difference to this, because this is where it'll actually matter. Think about it today on your way back home, because I'm going to end this conversation. I hope I've stuck to time. And we say that obesity is a low-grade chronic inflammatory disorder, whether you say meta-inflammation, visceral and ectopic fat, especially ectopic fat and not only BMI, is what fuels this entire disorder. Meta-inflammation starts and it ends up with all those disorders, be it ASCVD, CKD, MASLD, be it any of the other metabolic disorders that you're worried about. You are going to actually reduce inflammatory burden when you target obesity. And of course, you do now have molecules along with lifestyle measures to help you during this journey. And to last but not the least, prevention is better than cure. So we need to talk about prevention, we need to talk about treating early, and we need to be treating right so that we can actually make a difference to this entire meta-inflammation. Thank you very, very much.
Thank you, Dr. Shaila. That was an extensive and very elaborate presentation. We'll have a lot of questions on this, I'm sure, at the end. So now I request Dr. Mohan Magdum sir to come up to the stage for speaking on management of post-bariatric weight regain. So can I have Dr. Mohan Magdum sir is endocrinologist in Pimpri Chinchwad, Pune, has experience of 43 years in the field. He practices at Aditya Birla Jahangir Hospital, and he is DM from Merit University, and we know that he is the current president of Maharashtra Endocrine Society. He's been very active in obesity management and clinical trials in obesity. So he'll be speaking on the management of post-bariatric weight regain. Over to you, sir.
Thank you, Dr. Vaishali, Dr. Chetan, Dr. Sanjay Padke, and team SYNAPSE. So a very good concept of mind-body association and various aspects. So we are in obesity symposium. Just listen about relation between the obesity and the cardiometabolic system, obesity and inflammation. So naturally, what comes to our mind, what is the way to treat obesity? And for all those years, right from diet, exercise, and medications were very much limited. So first came the, prior to the potent medicines like this, came the bariatric surgery. And bariatric surgery also evolving over for more than a few decades now. And now we are seeing post-bariatric surgery weight regain, recurrence of obesity. So what we need to understand that obesity, like any other chronic disorder like diabetes, heart disease, hypertension, is a chronic disorder, a lifelong disorder. And it is not a something weight regain is a patient failure or that surgical procedure failure, but it is a part of the disease process which is continuous and lifelong. Um, So older view was that it is a cure is possible, but why now we know that we have to control it, and rather than terming it as a patient failure, newer concept is that it is a weight recurrence. So don't put blame on the patient only, but multiple factors might be involved. So there is a disease recurrence that what we need to understand. Usually earlier, like whatever maximum weight loss has achieved, nadir is achieved, thereafter we used to patient let go. But now we know that it is a long-term, lifelong follow-up and support would be required. So earlier, like long back days, maybe diet exercise was the only mainstay, then surgery, or now we are in the era of the GLP, GIP, dual and single. But it is not a only single modality which is addressing the obesity, and we know that we have to look it as a for effective management of weight, a combination of multiple things. So obesity is a chronic disorder that we know, and it is driven by various genetic, neuroendocrine, and so many factors. And whatever weight loss is there, that is not maintained. That is depended by various system, homeostatic systems, appetite regulating hormones, and reduce energy expenditure, so that it always tends to weight come back. And that's why this counter regulation we have to take in the account. So surgery, though favorably sets these points, still there can be weight regain. So we look at various surgical processes like round Y gastric bypass or sleeve gastrectomy. Within 1 to 2 years, there would be nadir. So this is the weight loss which is occurring. The graph support it is weight loss. So that is the percent total body weight loss is there. But maybe 2 years, 1 to 2 years, that nadir, the maximum weight loss would be stabilized. And thereafter, some weight regain would be there. Even then, by 5 years, majority of patients with these bariatric surgery will have some that maintain the whatever the weight loss. So that nadir we have to understand, then plateau. But again, some weight regain, though it is normal, depend on the procedure, how much patient is losing, that will start coming. Various long-term studies like this Swedish obesity study shows that as compared to control various procedures, they have longer duration of the sustained weight loss, maybe up to 20 years. But what the graph show that initially there is a weight reduction, maximum weight reduction needed, and then there would be start with the weight regain. So that physiology of weight regain or weight recurrence after bariatric surgery also we need to understand that it is not a lifelong benefit, and some weight recurrence or weight regain would be there. So two concepts are important, that some people don't lose weight adequately, the suboptimal weight loss would be there, and then there is a recurrence in the weight gain. So if less than 5% of weight loss is there of total body weight within 18 months, then we think that possibly it is not helping adequately that procedure. And weight recurrence is also important to understand, that will occur over a period of time. So when we think about this definition of weight loss, weight recurrence, then our approach to the patient that would be important, that will change. So from nadir, we have to, whatever the weight regain is from the nadir, that we have to take and understand. So almost every patient in 6 patients will have weight regain of more than 10% and up to 35%, 37% weight people will have significant weight loss, weight regain. And whatever regain is in various studies may be from 9 to 90%. So that sense, various studies, they are not uniformly assessed with each other. And that's why this variance 9 to 90% weight regain is understood to be after the bariatric surgery. But only it is not weight regain after bariatric surgery, it is a possibly physiology which is causing the weight regain. So what are the modality of weight loss? Be it a diet, drug, any device like duodenal ulcer, sleeves are put in the duodenum endoscopic procedure or surgery like gastric bypass. You can see that various people will have various weight loss. It is not uniform. And percentile also, if you see that weight loss is different. So the biology of that human, that person who is or was overweight, obese, and had lost weight, that is differs. And that's why we had to understand these people differently. Because it is a long-term disorder, it is a disease in itself, and by and large, like with aging, various factors, environmental influences, they are increasing, and with that the body fat or weight will increase. So if we offer patient a surgery, some weight reduction with their moderate, modest to significant. But thereafter also, over the period of time, over the decade, that weight would start coming down. So it is not the failure of the procedure or failure of the patient, but it is disease process, that is obesity, when the patient is gaining the weight. And why it is important with the weight regain, there is the chronic complications or morbidities associated with like type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea, and so on, massage, so many. So those are likely to be coming back, they will trouble patients, and quality of life would also deteriorate. So that's why the treating weight regain is important, weight recurrence is important. And various causes can be there. The anatomical causes, that is the structure of the procedure which was done, that the gastrointestinal bypass, that stoma may get dilated, pouch may get dilated, sleeve may get dilated, gastrogastric fistula can occur. And then can be behavioral problems like eating problems can be there. Then metabolic problems like hormones, after the set point, they start resisting the whatever the weight loss, and weight start getting back. Psychological problem, individual patient may have different psychology, depression, anxiety, and so on. And if patients on various medicines like antipsychotic medicine, antidepressant medicine, insulin, steroids, that would be also responsible for the weight regain. So various causes for weight gain, as well as various predictors of the weight gain like age, gender, what was the pre-surgery weight, and so on. So if we look before submitting patient to for the surgery or afterwards, the various predictors are there. Some are positively associated, that these kind of things will be associated with the weight regain, like a larger stroma, larger volume of the gastric pouch, longer duration from the surgery, maladaptive eating, like person start gazing and so on, emotional problems, instability, depression, anxiety. And the patients who are not in the follow-up, they are lost to follow-up, they tend to recur the weight. Similarly, the protective, the positive effects, like those who respond to GLP-1 very well after surgery, they have less weight regain. Those who remain physically active, less weight regain, as well as the self-esteem and the social support. So family support, group support, which would be very important. Diet like fruits, nutrients, fibers, those would be very, very important. So the structure of follow-up of these patients has to be there. So when these patients with weight regain is there, we have to work that. Like we can go briefly in the history. So what was the maximum weight loss magnitude when the patient achieved the nadir? What was the trigger? Whether personal event was there, some maybe breakup, divorce, loss of somebody in the family, so that triggered, or any other factors. So that history has to be important. Dietary, behavioral history is important. Then we have to assess their nutrition and various other parameters that we need to take. And ultimately, the surgical procedure itself, whether that is a problem, and for that various procedures like endoscopy or the other procedures would be important. So the diet was discussed, but the important aspects like protein, vitamins, micronutrients, and for bone health, calcium, vitamin D, and so on. So that these things we have to keep in mind, we have to assess. So these are very integral part of the weight maintenance after bariatric surgery. If we do only bariatric surgery and don't give that structure program, so that is also going to be act negatively. So screening from eating pathology, like patients start binge eating, maybe grazing small feed, they can starting very high density liquid, like high calorie liquids they can take, or the portion of the meal after over a period of time start going up. So that we need to assess. Then mood and mental health, because depression, anxiety, though we feel that it is not on the paper, but no, that's why that is important that the body mind association is very, very strong, and that we need to understand, assess in these patients. And ultimately the support system, family support, group support, society support to maintain the weight which is lost, that would be very, very important. So when we suspect that there is certain problem, and when we'll suspect that some problems or some complaints are there, that reflux is there, dysphagia is there, dumping symptoms are there, abdominal pain, vomiting is there, we may suspect there is a problem with the surgical procedure which was done. And if patient is having disproportionate weight regain or rapid weight regain after surgery, that also we have to suspect. And various procedure related suspicion we have to keep in mind. So simple procedures like GI endoscopy would be used, or contrast upper GI study can be done, or advanced CT scan, and procedures can be done to assess the whatever the problem of that person is having in the surgical process. So the dietary part is also important, lifestyle is also important. But lifestyle itself is not sufficient to address the weight regain. It would be cornerstone, it would be platform on which behavioral therapy, group therapy, pharmacotherapy, and other aspects that would be based. So, but that understanding of the patient overall that we need. The patient who is lost to the follow-up, so we can call back that patient, and that can be included in this. So it is very, very important to continue the post-surgery follow-up in these patients. And along with diet, exercise is always important. Just now discussed aerobic activity, resistance training, very, very important. Self-monitoring of that weight, exercise pattern, that is important. And ultimately behavioral support, the family support, particular team support would be important. There is various modalities of treatment. Pharmacotherapy ultimately would be there after assessing the patient, psychology and all of the aspects, diet, physical activity. Pharmacotherapy is also having role. And the player of the era or the maximum noise level is with the GLP or dual GLP, GIP is there. Parazole, phentermine, topiramate, which was there for a short duration available in India. Though individually they are available, but as a combination they are not available. No, oral statin is still available. And they have various degree of the weight reduction in those patients who are regaining weight after the bariatric surgery, like liraglutide, semaglutide, up to 9 to 12% weight reduction after regain can be there, with tirzepatide up to 15% weight reduction after the metabolic surgery, and then weight regain that can be there, and other may have modest. So the potential benefits of these GLP, GIP is that they modify the appetite also, then satiety would be also there, additional weight loss can be there, cardiometabolic, diabetes, hypertension, protective effect would be there, but also the adverse effect, nausea and all those things also we have to keep in mind. Safety concerns, now we are using it extensively, so we know. Just to sample that with liraglutide as compared to placebo, there was significant weight regain in patients who, weight reduction in patients who had regained the weight. Same way, semaglutide is also extensively in various study, and one of the major study, Barry STEP, again placebo-controlled study over a period of 2 years, that also showed significant weight reduction as compared to placebo in those patients who had weight regain. So whether now we have to think, or we may feel that whether bariatric surgery is useless, and now all the patients we should put on the anti-obesity medications like semaglutide or tirzepatide, or newer medicine which are coming? I don't think so. It is a combination. So choice between metabolic bariatric surgery and therapy, that should be individualized, and patients who are modest weight, more than 25, 30. So now we know that more than 30 BMI is the indication, and with more than 27 with the comorbidity is indication for these medications. And for bariatric surgery, it is more than 35, or those who are refractory type 2 diabetes. So these two therapies, that is the metabolic or bariatric surgery and the obesity medicines like GLP or dual GLP-GIP agonists, they would be using in a combination. Like a cancer patient comes to our clinic or any specialist clinic, it is not only surgery, it is surgery, chemotherapy, radiotherapy, multidisciplinary approach we give that treatment so that the maximum best results would be there for the cancer patient. For same way, for obesity patient also, we have to think not only bariatric surgery or not only GLP, GIP agonist, but a combination of these therapies. And when this is also not giving effect, and especially those patients when we feel that there is a structural problem in the surgical procedure as evaluated with the endoscopic procedure, then we can use the transoral outlet reduction, that endoscopic procedures can be done, and wherever we suspect that the stoma is dilated, that resuturing can be done, and that can give the again modest weight reduction 6 to 10%, and it is durable up to 5 years as well. So that we have to choose patients wisely and correctly, so we can evaluate them properly, and then the various conversion procedures like sleeve to RYGB, that is sleeve to single annulated duodenal bypass, anastomosis, or pancreatobiliary diversion, and so on. The advanced procedure can be considered. So finally, what we need to understand, that is not a single modality is there for obesity, and multiple modalities we have to consider, like from the simple lifestyle, dietary, behavioral, psychological assessment, physical activity, exercise, and that will become platform for the weight reduction as well as maintenance. Also, after the post-bariatric surgery weight recurrence, that would be platform. On that platform, we have to build the interventions like pharmacotherapy, like two most potent drugs at present are available. And as Dr. Chadda mentioned, there are newer medicines in pipeline as well. And then there are beyond the pharmacotherapy, then endoscopic, transoral, that stromal suturing or modification that can be done. And finally, the surgical revision, which will be most extensive, but most greatest achievement would be their greatest weight reduction can be achieved, that can be done. So that is a briefly flow chart how you can approach the patient. So finally, what we have to remember, that obesity is a disease, and any weight regain is not failure, but is a part of the disease process which is progressing over a period of time. And we have to evaluate these patients, what is the factors are involving for their obesity as well as weight regain after the therapy, medical therapy, same way after the surgery also. Then we have to think stepwise, and what would suit to what patient, that we need to understand first ourselves, so that we can appropriately offer maybe pharmacotherapy initially, which is comparatively less invasive, but everything is on the platform of diet, exercise, behavioral assessment. And there are some procedures like transoral, minimal invasive, and then ultimately the invasive procedure, resurgeries also can be done. And finally, we have to remember that is a long-term care, it is a not short-term, it is a lifelong follow-up with the therapies. So reframe obesity, its definition, it is a long-term disorder. Proper diagnosis has to be there, evaluation has to be proper, so that we can offer the appropriate therapy to the patient. And then as per the patient problem, we have to treat them stepwise, and we have to ourselves balance rather than going enthusiastically overboard. We have to assess these patients and treat appropriately, so that we can get the proper benefits. Thank you.
Thank you, sir. We are very grateful for your time. Now I would like to invite Dr. Sujit Chandatra sir on stage. Sir, first endocrinologist in North Maharashtra, multiple distinctions in MBBS curriculum, first rank and DG Paranspe Gold Medal in Pune University for MD Medicines, first rank in Mumbai University in DM Endocrinology, first rank in India for DNB Endocrinology, winner of AV Gandhi Gold Medal and award worth 1 lakh for best research paper in India, winner of Hargobind Scholarship in Studies in Abroad, multiple publications in pre-renewed journals, multiple presentations in academic meeting and conference, principal investigator in multiple prestigious multinational clinical research trials, presently practicing in Nashik with 80,000 patients database. Thank you, sir. You can.
Thanks a lot for very kind words. And thanks, Vaishali, and everybody for inviting me here. So the topic was resistant obesity. What is actually resistant? In 1970s, suppose if some patient had say prolactinoma or pituitary adenoma or something else, we would just do an X-ray and show the X-ray to the patient and say that there is nothing wrong with your head. You're absolutely fine. The patient would not be cured and we would call it resistant headache or kind of a resistant disease. So what is really resistant is a question. It's the label of our current therapeutic ceiling and understanding. It may not be the laziness in the obesity. It may not be something really happening which the patient cannot help or so, or maybe is not responsive to the treatment. Maybe it's not our understanding currently. So I've designed this in a very unique way, not like a typical lecture. कोणी तकेशीज कॅसल म्हणून एक सिरीज यायची पूर्वी. Those who are Buddhas like me, long back in the TV, it was a Japanese game show where 100 people used to start from one end and only 1 or 2 used to be the winners at the end. And there was a funnel. They were actually getting eliminated at each step. So we'll think of that line. Imagine a person coming to your OPD, you're treating, or maybe you're involved in some treatment of that sort. A person of BMI of 30 with maybe slightly increased blood pressure, slightly increased sugar, slightly elevated lipids, but nothing much happening there. Imagine there are 100 such patients. 100 असे लोक आहेत, and what would you do? We are not going to put the patient on semaglutide in the first go. We are going to tell them to do something in the beginning. So we would think of the escalating step. The first advice is usually, भाई diet करो, exercise करो, कुछ तो भी करना चाहिए. It is not going to be go to the doctor actually. So initial advice would be something like caloric deficit or balanced deficit diet, what we say in the science. So we think of the maintenance calories for that patient. We think of the metabolism. We prioritize the proteins. Of course, not too much of a protein. Protein restriction can increase the lifespan nowadays, we know that. We should measure the cooking oil, swap the high calorie snacks. We should control the carb portions, very important. Insulin resistance is the mother of all non-communicable diseases. Walking more daily, 7,500 and 8,000 are the studies now. The Japanese number of 10,000 of course remains, steps per day. We should cut the liquid calories, not in our country much, but all the Western countries are actually afflicted by the soda and the Coke addictions. And we should of course repeat more smart meals. So this is the balanced deficit diet. And that is what the step everybody should take in the beginning. That's what we trust. So what would happen? Now these numbers are depending on the multiple clinical trials and experience of the clinicians. Those may not exactly match with the literature, but it is actually representation of a fair number per se. So out of 100 people who started the race from the first end of the Takeshi's castle, everybody supposedly did a 500 to 750 calorie deficit per se, and they started following things properly. So out of 100, 35% would respond. That's a good number for balanced deficit diet, but not a great number really speaking. So otherwise, the good advice of eat less, walk more, and be mindful, that doesn't hold true for 65 of our patients. They get carried forward. And why they are resistant? There is a poor long-term adherence to the lifestyle. Diet fatigue is a term. We live in an environment which is actually proponent for bad food, the cost of it. There is something called adaptive thermogenesis, and there is a fight between the body's maintenance mechanism versus weight loss mechanisms, and the resting energy expenditure falls. There is something called NEAT also, non-exercise activity thermogenesis, that goes down. There is change in the ghrelin and the leptin and the peptide YY drive per se. And there are unaddressed emotional eating, sleep debts, chronic stress, and the cortisol resistance, so-called, and hypercortisolemia. And of course, this is like sab ghode 12% kind of a treatment. It doesn't fit everybody. So 65 would go ahead. They get carried forward. What is the usual advice after that? In most of the clinics, not in your clinic specifically, possibly, but many people would go for something else if at all this is not working. So people go for intermittent fasting, a very good fad now, good idea. Go calorie free for some time, so the body's glucagon would be utilized, the liver glucagon would be gone, some fat would be utilized, some ketosis would be developed. There is a doctor in BBC called Michael Mosley. He was studying alternate day diet. There was a doctor called Christy Varade in the Institute of Longevity, but he came up with his own diet called 5-2 diet. Only 2 days a week you go on restricted calories, 500 calories, and other days you eat normally. And of course, the typical 16-8 method. You remain fasting for 16 hours and eat in 8 hours window. It's a good idea per se, and there are multiple studies which show that this method would be better than the balanced deficit diet, and people's adherence is much better. The so-called Dikshit diet is kind of, version of this, but doesn't achieve ketosis. So I would not include that in here, though it's indigenous. So what would happen? We had 65 people remaining out of that 100, and 20% further would respond over balanced deficit diet. And we would be left with 50%, 52 people from the beginning 100. But still, people do fail on this window also. There can be compensatory overeating when people are allowed. It is 8 hours eating. There is no calorie counting per se, because this is by definition a simplified program. People don't have to see what they're eating. They don't watch it. They might prefer fatty foods. There could be something mismatch with the occupation. There could be a chronotype. Some people digest the food better in the mornings. Some people do it in the evenings, and there are chronotypes for that. The weight would plateau because body would adapt to that feeding schedule finally. Body को लगेगा कुछ तो भी बाहर चल रहा है, इस आदमी को खाना नहीं मिल रहा है, something's going wrong, there is famine outside. Body would resist further kind of weight loss. And there is of course no quality control also. Forget the quantity, even the quality control is not there. So of course we will have rest of the people who would be resistant to this kind of a diet. So again, we are left with something called resistant obesity. We can go one step further. There is something called OMAD. There are multiple fat diets, but this is actually proven by science. There are some RCTs here. So beyond intermittent fasting, what we can do, finish your food in 1 hour, and 1 meal a day would be the concept. It is said that even if we eat 1 breakfast every 48 hours, we can sustain our life forever, and we still would be doing good. And we eat too much of food, that is what is really said. But OMAD does have some data, that's why it features in our game cascade. And if at all we monitor it properly, the protocol actually could cause good trigger of autophagy. All these disease cells, they thrive on the glucose, and if they're fasted, they're starved, the bad cells are eliminated, only the good cells do remain. Some time back, we heard a story from Gangadhar sir that in Roman civilization, in Spartan civilization actually, is to keep the infant outside for 24 hours. If the infant survives, they is to take it in. Otherwise, the infant was left to die so that the society could be fitter in general. So this is like the autophagy happens and the bad cells are eliminated. Only the fit ones do remain and they do multiply. It does improve insulin sensitivity. There is a data on visceral fat also. It does boost fat oxidation and it does preserve the lean body mass that we know. It does, of course, reduce inflammation and there is a data on CRP also. So OMAD would be the next step. So what happens by the data at present what we have? So we do have a severe restriction to a single daily meal. It's a large acute deficit and prolonged daily fast. But out of our 52 entering this step, maybe 10% would respond further. So those who were resistant to intermittent fasting, they would respond here well. And we would go to 47 patients now. It's 52% cut 10, 52 cut 10% of course. So this is kind of a binge eating and it might actually cause some food eating disorders in some people. There's a very high dropout because the sustainability may not be good. In a social situation, a person cannot eat. The lean mass loss could be there. Gallbladder stasis, gallstones could be possible actually. And there could be some people who will end up with some anorexia nervosa or bulimia, or maybe other eating disorders. So we have to be a bit cautious there. Do not put patients with slight borderline psychiatric disorders on this kind of a regimen per se. Another fad now, keto diet, or there is something called zone diet, Indianized version of the keto diet. And we know that we have to restrict the carbs severely in this kind of a diet. And many celebrities and many big figures, sports people are actually using keto diet. So they employ fat of 75%, so-called healthy fats, so-called non-saturated or monosaturated fats. A protein intake could be variable, fat and protein ratios could be variable, but one thing they accept that carb should be less than 5%. Some keto people keep a cheat day, but that actually defies the purpose. But in general, a keto should be maintained for minimum for 14 days to get a real good effect on the body. So that would be the next logical step. So as we said, carb restriction less than 50 gram per day. It does shift the substrate use for the caloric requirement for the body to the fats and the ketones. We know that it does lower the insulin. It does suppress the appetite. Long back for epilepsy, we didn't have too many treatments and ketogenic diet had come for epilepsy long back. And those people really reverted diabetes sometimes, epileptic diabetics. And that's how those thinking processes did start. So 15% of our 47 would respond to that. And that's good number actually, not a very bad number. But many other people are resistant. Why it does happen? There is difficult adherence. There is something called keto flu. People can get a lot of constitutional symptoms, constipation, social restriction is there, compensatory hyperphagia and very strict ketosis lapses are possible. When people break it, they can gain the weight. There could be dyslipidemia in some people. Atkins diet was one famous diet actually of a keto diet, but Atkins died of heart attack. People must be knowing that really speaking. Regain on carbohydrate introduction is very, very common, and the counter-regulatory hormone adaptations, though slightly tougher as compared to the balanced deficit diet, it does happen on ketogenic diet too. So, of course, what happens after that? Then we go to the drug treatment, which is the cheapest possible, easiest available drug, was Orlistat till now. We have only 3 drugs right now in India which are approved for obesity therapy. Orlistat is the oldest one. All others are gone. Long back, we had sibutramine and rimonabant and other drugs. And those who are old like me must be knowing about those, but they are off now. They are gone. Only Orlistat is the medication apart from GLP-1 receptor agonist, which is really approved. Even the topiramate, phentermine, that is actually not approved at this moment in India. So it is a lipase inhibitor. So it does reduce the absorption of lipids from the intestine. And what would happen once we do everything, all the jugglery with the diet possibly, which is allowed in science, what would happen? Orlistat would reduce the pancreatic and gastric lipase. It would block the absorption of up to 30% fats from the dietary sources. It does get excreted unchanged, truly speaking. what would happen? Further 10% of patients would really respond to this step, a good drug per se, and maybe 36 of those 100 are now carried. Those are still resistant, truly speaking. But why the people are resistant for it? There is a efficacy ceiling. There is a modest 3 to 4 kilogram of weight loss. GI side effects are there like steatorrhea, urgency. It would limit the adherence per se. You can get fat soluble vitamin deficiency if at all we consume it for a longer time. And there is no effect on the central hunger drive. Yesterday, Vaishali mentioned that those people who have got emotional eating, there is no use of orlistat. That was the statement made by her. Exactly the point what she had caught today, what we are talking. So 36 would go ahead. We know that metformin is not approved for weight loss in India, but in our experience, we keep on using it for many obese patients, whether because they have insulin resistance or because of something else, and it does help to some extent. A great metabolic modulator per se acts on AMPK pathway. It does reduce the hepatic gluconeogenesis, activates the GLUT4 receptors, and there is, of course, intestinal glucose absorption could be reduced to some extent. So in general, we do have a good improvement of insulin sensitivity. The theory is that insulin resistance is driver of the obesity, so this should work to some extent. But of course, the mechanisms are good. On theory, it is fantastic, works very well in the insulin resistant PCO people. And what would happen? 8% further would respond to those. But 33 people would be still resistant to all these steps. Everybody has undergone these steps now. But 33, which is a very big, 1/3 is the number which is still remaining and they have not responded. Why this would happen? Because it's a very mild drug for weight loss, 2 to 3 kgs per se. GI intolerance would limit the dose. We can't really scale the dose. It's not an obesity labeled indication, so it's on our own risk per se. And there is no meaningful action on appetite regulating factors. Though there is some nausea, there is some curtailment of the cravings, but a normal appetite doesn't go down. Somebody eats chronically more, nothing happens. And of course, there are many side effects like nausea, diarrhea, stomach upset, metallic flavor, and fatigue, and so on and so forth. We can get lactic acidosis, a theoretical complication, not too much frequently seen nowadays. So now this is the time we finally go on the buzz of the therapy now. The whole pharma industry is moved by these molecules. So it's semaglutide, tirzepatide, or a triple agonist that is going to happen. It's a central appetite suppression by hypothalamic GLP-1 GIP receptors. It does act on the gastric emptying. It does act on the satiety, and of course there is GIP mediated effects also. So 70% of this group would respond. We should remember that these drugs are excellent, but they are not a complete kind of a solution. Not everybody would respond to these drugs, and that we should absolutely remember. And why people are resistant, these causes are very important. It's very logical why would some people not respond to earlier dietary interventions, but not everybody who's obese would respond to either tirzepatide or semaglutide. It's very, very important to know. There are dose-limiting side effects. There could be cost access injection related to problems. There could be truly biological non-response. We can have a receptor density or a sensitivity issues, or there of course could be like truly biological non-responders to these molecules. The weight regain does happen after discontinuation. The hunger drive would actually return. And there is, of course, compensatory hyperphagia later on. And the NEAT goes down, as we said. Non-exercise activity thermogenesis would really go down on these drugs. So 10% would be really resistant. Those are truly resistant by all the means of the non-surgical intervention per se. So we do not know what to do with these people. A physician's scope of treatment is over now till the time we have a triple agonist or CagriSema coming in, as Chadda sir mentioned some time back. But right now, a physician's capacity is over. The therapeutic ceiling is reached. So these are the people. We started with the 100 patients. We started with balanced deficit diet. We went to intermittent fasting. We went to OMAD. We went to keto. We went to orlistat. We went to metformin and GLP, GIP. So really, those last patients were truly resistant. Then we can go to the least amount of cutting or intervention. That would be an intragastric balloon would be an intervention. There are two ways we can do it. We can put just with a Riles tube that would remain for 6 months or so, or we can put it with the use of an endoscope, and that would remain up to 2 years. The costs are quite a lot, 2 to 3 lakhs right now. After that, the balloon gets deflated of its own and it's passed in the stools. A good intervention, and those who would not respond to tirzepatide, semaglutide, we can put those patients on this intervention. So out of those 10 remaining really bad, resistant, pharmacologically difficult dietary intervention impossible patients, 35% of them would respond to it. And we have 7 patients would be really, really resistant. They are carried forward. So why these are resistant? The effect is temporary. It does actually, the weight does regain after the balloon is gone. The tolerance is bad because there is nausea, there is cramping, there is a foreign body in the stomach. It's a purely restrictive mechanism. There is no hormonal change or intervention per se. And of course, underlying behavior, genetic, all those issues are actually not addressed. It's just a mechanical device put in the stomach. So this is all done now. A balloon is done now. Now this is the time to send the patient to the surgeon basically. Now there is nothing happening, nothing is remaining. It's all over. So now we can go to a bariatric surgery. We had an extensive lecture, excellent lecture from Magdum sir some time back. And we know that many patients would respond. It's a comprehensive metabolic and anatomical and everything would be actually altered in the bariatric surgery procedures. But still, not everybody would respond there. There are people, as sir showed in the slides, that there could be inadequate weight loss. And later on, of course, there is regain of the weight on many of the patients. So out of 100, 4 would still remain. There could be maladaptive eating, grazing, sweet eating, loss of control, binge eating can happen. There could be anatomical issues, inadequate nutritional follow-up, underlying psychiatric or eating disorders could be there, or unmasked genetic monogenic causes could be there. So these patients, those 4 are really, 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 truly resistant people, truly speaking. Now our ceiling of knowledge is actually reaching to its end. Maybe finally, these are the ones which we should be actually targeting. So these last 3-4 patients, they have failed diet, fasting, pharmacotherapy, a balloon, a surgery also. Now the pretest probability of a monogenic or a genetic or a syndromic cause is very, very high. So these are really, truly troubling cases. And a specialist should be involved here, not a common metabolic physician should be touching these patients. Now we started with 100 patients, but we should know that those syndromic causes come up early in the childhood and we can have other dysmorphic features along with that. So we should think of those cases when there is severe early onset obesity in less than 5 years in children. Extreme insatiable hyperphagia would be an indication. Developmental delays, dysmorphism, hypogonadism, and a strong family history could be actually other associated things. So we can have syndromic forms of obesity in this resistant obesity kind of category, or we can have non-syndromic forms. In syndromic, we can have a chromosomal kind of a rearrangement like Prader-Willi syndrome, or a pleiotropic arrangement like Fragile X and Cohen syndrome. We can have monogenic and polygenic obesity with multiple gene defects per se, and these are the ones which really pose a clinical challenge to anybody. Why the monogenic obesity? Because these genes are involved in the downstream of the weight regulation kind of pathways from hypothalamus till the adipose tissue all over. Anywhere the defect comes, we can actually gain too much of a weight. So this is the flow chart of where the genes are involved, and it's very, very easy to understand why we can have monogenic obesity at each step if there is a genetic modification or a deletion or a nonsense mutation or something like that. And we do have this kind of a mechanism where the genetic change can affect the energy expenditure, food intake, and further handling of the calories per se. So when it was all resistant, we labeled it. Now this is nothing can be done. This patient is out of our league. We have a drug called setmelanotide. It's a MACR agonist. It's FDA approved for POMC, PCSK1, and LEPR, that is the leptin receptor deficiency, and Bardet-Biedl syndrome. So we don't have to really go into the details of the drug, but we have data, it's FDA approved now. So this is a clearest proof of today's message that resistant often means not yet correctly diagnosed or not yet really correctly investigated, or we do not have knowledge. As I said, in 1970s, an X-ray of a head would mean that the patient was all right, and now we know what actually does it mean. So we know that when something is resistant, of course, we don't know yet what is happening. It is just like calling something like essential hypertension. We don't know what is happening. So we do have the leptin melanocortin pathways, POMC pathways, and there are multiple therapies would be working on that. Setmelanotide would be example. Of course, GLP-1 would be acting on that finally. So these are the full funnel. From the 100, we are left to last 3 or 4, which could be actually the genetic ones or the syndromic ones. And this is the data, this is the literature right now, say what step would give what kind of a response. All others are naturally resistant per se to that step, but of course that doesn't mean that we don't have the next step. So we should always think of a next step when something really, truly resistant actually comes across our way. So these are the key points to remember. Obesity management is a funnel. It's not a one step fits to everybody. There is not a single decision. Each rung filters the patients through the specific identifiable mechanism of failure. Failures at each step are not patient failure actually. Those could be metabolic adjustments. They reflect predictable counter-regulatory biological changes. At the bottom of the funnel, the pretest probability of genetic disease is very, very high. And this population deserves testing. Test those people when you don't know what is happening, truly speaking. Don't label them non-compliant, maybe check their genes or chromosomes. And a resistant is placebo holder for not yet understood and not a diagnosis itself. Thanks a lot.
Fantastic talk by Dr. Sujit. And now I welcome all the speakers of the session for a panel discussion. So my question to Dr. Magdum, sir, how do you deal with dumping syndrome, which most of the bariatric patients come across, or they do have postprandial surges of sugar, or they could have hypoglycemic episodes also. So how do you really counsel or look in for these in patients with post-bariatric?
So first the history, which is important. So correlate the at what time patient is having symptoms after meal, so that understand what is it dumping or what. And then we'll advise the modify the medication, not medication, the diet. So patient can have a smaller meals so that the dumping effect would be less, carb content would be reduced, so that the insulin surge would be less. And then alpha glucosidase inhibitors can be incorporated so that the digestion slows down, so that the chances and severity of dumping syndrome can come down.
So anyone has any questions for the, yes, please.
Hello.
Yes.
Sir, you said that for once daily meal, there is higher chance of stone formation, gallstone formation. For 16/8, how much chances are there?
They are much lesser because the gallbladder contracts when you eat something. So if you go for prolonged fasting, like 36 hours and 5 days and 4 days, many people, Chetan is not here, but in oncology, this fad is happening for a long time. And we get so emaciated patients because of this fasting, because they have heard somewhere that you fast for 7 days and the cancer would just disappear. So when then that happens, the gallbladder doesn't contract at all because it has to contract in the response of food as a physiology. So when it doesn't contract, there is a stasis. So you form the sludge and the formation of stone is more. But 16/8 doesn't form that kind of a challenge. OMAD does form a challenge.
And what is in case of Wang Chung now? Wang Chung doing 27 days of
Manu fasted in Delhi.
fasting. People say that he was drinking from the steel glass and not from the glass transparent. So I don't know whether I would not say further anything.
sir, one more
Just
question.
1 minute, let me finish this on the gallstones. Any weight loss therapy increases the risk of gallstones. So nowadays with these GLP-1 analogs, we are worried about it. But like as you said, dieting, fat dieting, bariatric surgery, anything can lead to weight loss.
Especially rapid weight loss.
Yeah, I think the right word is rapid weight loss.
Anyone with biomass, hey, BMW 25, what is your advice?
In
BMI of 25.
lose some weight. That's what. Make it 23. In India, we need 23.
But what is your
Shaila,
advice?
would like to add to
But
this?
I would suggest more of exercise in this patient and maybe look in the diet in terms of protein. Look at the comorbidities he is having or comorbidities in the family so that the risk profiling would be better and accordingly how aggressively weight reduction or weight maintenance that would be important.
In fact, Vaishali chose only because we have BMI less than 25. We have to go to the gym for 2 months before we prepare for the lecture.
Check the body composition also. Sometimes a BMI of 25 may have actually hidden fat. Like if you look at some of the BMIs of some of us, you may find that the muscle mass is less, but the visceral fat is more. So the BMI may not be an absolute accurate reflection. So check for central obesity. And if the visceral fat is more, then you may need to tell the person that yes, you need to still be more active of diet. You need to be more careful with your diet.
There's a BMI paradox. Athlete with 5% body weight would be also obese because a rugby player, a huge one, muscular man, but BMI would be more, but they are not metabolically unhealthy. So BMI paradox is actually there. So if you talk about normal population, for India it is 23 as a normal cutoff. More than 23 we are overweight. More than 25 we are obese. So the definitions are different in Caucasian and Indian population.
See, in fact, the definition of obesity comes with BMI, but when I'm taking talks on obesity, I tell people who have to treat obesity, they should forget BMI. Because if you are thinking of BMI in treatment of obesity, you're not doing justice to fat health. Adipocyte health is what is more important. So, for example, you have a BMI of 21 and the patient is diabetic. Won't you think of improving the metabolic fat? You would. So I don't think that BMI should be a hindrance mentally or physically also to prevent treatment of metabolic dysfunction, and that's what our speakers also highlighted. Yes, sir, please.
So after ICMI IDEP study, the concepts of like obese patient, yeah, mono patient, that is metabolically unhealthy, non-obese means BMI was they would be normal, but central obesity and they may have carry different risk factors or might be already having diabetes and all. So only BMI may not be sufficient. Waist circumference, especially one of the other indicator is like neck circumference or waist to hip ratio, or waist to height ratio. These would be important anthropometric measurements that we have to look in so that we can identify who are.
This question is for Sujit. In your Takeshi's Castle, how long do you wait at every step to tell that these are responders and these are non-responders?
Yeah, I had shown the definition of resistance to the therapy, that is inability to lose 3 to 5% of weight in spite of 6 to 12 weeks of intervention. So that is the definition of resistance in obesity kind of a funnel. Resistance could be different and in different disorders, but this is what 6 to 12 weeks you can choose whatever you like and 3 to 5% minimum weight loss.
So possibly that concept is also changing, say within less than 5% over a period of 12 weeks. So then it might stand true like with medications, like suppose tirzepatide we are using and we are giving it for a longer duration and they may have weight reduction because up titration itself would require 5 months.
Yeah, that is on maximally tolerated dose. Actually.
Hello, I'm a gynecologist, and many women put on weight perimenopausally or postmenopausally. What is your general advice? Shall we give advice only for healthy lifestyle, maintain diet and exercise, or they should go for all this obesity checkup and be put on semaglutide and all those things?
Ma'am, perimenopausal, there's always going to be some amount of weight gain. That is a result of the process of the journey only when you're perimenopausal. Now, if the person is able to maintain or even if I don't say lose weight, even maintain weight with a lifestyle intervention at that point of time, that is the beginning of the journey of as far as weight is concerned. It will all depend upon what degree of weight we are dealing with at that point of time. It will depend upon whether this person has now decided to come to you for a weight loss journey. What was the past history, whether this patient, for example, had PCOS, this patient had a history of GDM. So there is nothing like an individual decision which you would take only at the time of perimenopause. It will depend on all these factors, what kind of comorbidities we are dealing with, what kind of other complications we are dealing with, and then we decide regarding, because though when you look at the decision to initiate any kind of therapy, be it lifestyle, be it medication, be it surgical, the guidelines will tell you that less than, for example, more than 27 one comorbidity, you can plan a medical line of therapy. More than 30, you go accordingly to bariatric surgery. But a lot of individualization is involved in this journey, ma'am, because and that would decide which patient requires what. When we talk about guidelines, we're giving very broad guidelines. In your clinic, you're the best person to know what that person's journey has been like, ma'am.
But I understand the concern because during the postmenopausal transition or menopausal transition, lot many things that lady is handling, emotional, vasomotor symptoms, family plans, her own identity. So obesity or weight gain is one of the additional factors. So that she might be very much concerned, and very important to address that. But physiology we need to explain to the lady so that she can take in tide. And naturally the diet, exercise and all the cornerstones are there. Pharmacology that there are.
How beneficial is fasted workout?
Fasted workout.
Fasted workout means biochemistry, doing the tests in the past.
Workout.
Going for a workout.
Workout.
Yeah, yeah.
Exercise.
Can I take that?
Yeah.
You want to-
No, no, Sujit, just start. Then I will.
There was one study which showed that fasted sympathetic activation by cardio was beneficial for visceral fat loss in a short term kind of a scenario. Long term, the body adapts. Whatever you do, it doesn't matter. And if you're going for weight training fasting, that is not advisable because you actually don't put on muscles if at all you're fasted. So then that is actually detrimental. But you can go for cardio, and the main mechanism for visceral fat loss would be sympathetic activation because of intense cardio exercise. So weight training doesn't help in visceral fat loss per se. That is what the current data says. So it is best not to go for fasting. There are chances of injury, fainting, all other things happening in the fasted workouts. People like us should not do that. Maybe 18 years old can do that. That would be easy for them.
Sujit, is there some data saying that evening workout works better than morning workout?
Actually, there was some data with
Yeah.
evening workout, but the problem was that it was affecting the sleep quality. So it actually reduces the lifespan because the sleep quality goes down. The resting heart rate goes up if at all you exercise beyond 7 p.m. So like evening workouts are better for muscle gain, body composition, but not in the long run.
Can I
If
add to? Yeah, please.
If I may just guess that morning exercise, fasting is morning exercise, will give a lot of opioids like secretion. So that will give a feel good factor to also throughout day, the mood. And also the basal metabolic rate would be setting at higher level. So the same amount of fat and calories would be burned better. I would be right?
The best way is to, like, if you do muscle training in the morning, you get fatigue the whole day. So the best way is to do cardio in the morning and muscle training in the evening before 7. Finish it off.
Before dinner,
7.
before 7.
7 p.m. So fasting, cardio is the best. Evening muscle training is the best. You finish your work, otherwise you go fatigued in the workplace, and that would actually affect your work quality.
This is, please listen to this carefully, means half an hour morning remove, half an hour evening remove. Right, Sujit?
Okay, I just add a point to the fasting because we are working in mind-body medicine. Fasting has two implications. When a person is fasting, there are two ways to look at it. One is fasting out of displeasure. So there has been no time for eating. Today I am very hungry, but I am curbing my hunger, and that is a stress to the body, and that is going to give a sympathetic overdrive. And the other fasting is what we talk in Ramadan and spiritual fasting and mental calming fasting. So that increases the parasympathetic drive. So in which state you are doing the exercise also matters. So that fasting, if it is a stressful fasting and you're doing an exercise, you're worsening the cardiac health. You're not benefiting it. So it is said that when a person is peaceful and then doing exercise, so काल सरांनी सांगितलं की action, relaxation in action, and vice versa. Action in relaxation is also very important. So I think in fasting we have to think of this thing: how the person is fasting. Is it stressful fasting, or is it a peaceful fasting?
Even activity does the same thing. बस पकडायला कोणी पळत असेल तर ही डझंट गेट बेनिफिट्स ऑफ एक्झरसाइज. त्याला माहिती आहे मी पळायला पळतोय माझ्या बॉडीसाठी, तर यू गेट बेनिफिट्स. देर आर प्रूव्हन स्टडीज फॉर दॅट यू आर डुईंग सम ॲक्टिव्हिटी जस्ट लाईक एक्झरसाइज, बट इफ इट्स आउट ऑफ कंपल्शन, म्हणजे हमाल लोकांची बॉडी नाही बनत, पण तेवढेच इकडे जिममध्ये डबल पैसे देऊन तेवढीच वजन उचलून मसल्स आर बिल्ड. सो दॅट्स द आयडिया. कॉर्टिसॉल.
Gita works here also. Intention matters.
So this reminds
Intention
me,
matters. Yeah, that's
Vaishali
Yes.
and Shaila, this मी दिवसभर घरी काम करतो.
that's true.
So I tell these
ma'am.
ladies or any people, this is the bonus and that is not the salary. Salary you have to earn, and bonus is this household work.
What is the role of gut microbiome in the inflammation obesity?
So actually, we had a huge discussion on gut yesterday,
Not
but I
there.
think you can take this question.
The future is going to be gut bacteria. Next 10 years, you'll keep on getting more and more and more and conferences in gut bacteria. In fact, in diabetology, when we are endos, आम्ही डायबिटीसला डाएट देतो किंवा डायटिशियन डाएट देते. मी सकाळच्या 15 कॅलरीज कमी करते आणि रात्रीच्या 10 वाढवते. तर वी आर ॲक्च्युअली अशेम्ड अँड लाफिंग इन द माइंड. कारण दोन माणसं एकाच फूडला वुड रिॲक्ट इन अ डिफरंट वे. ट्विन्स, if two twins are given shrikhand with diabetes, one would have high sugar, the other would not have. And burger would increase second person sugar, not the first one. So calories intake and all that doesn't matter. How the gut bacteria would interact in and whole metabolism plays out. So everybody's got individual response to individual food, and that all is determined partially or maybe majority by gut bacteria. So that's going to be the future now. 10 years are going to be specific disease-oriented gut bacteria therapies and all those going
In
to
fact,
happen.
we spoke on microbial endocrinology, how microbes change the hormonal milieu, change the enteric nervous system, and the behavior of the person. So the eating behaviors are determined by
Individualize.
microbes that you hold into the gut. So that's, yes, ma'am.
So it comes from me दिवस भर घरी काम करते. What I want to say is कि आप खुशी से काम कर रही है या आप दुख से काम कर रही है. अगर आप दुख से काम कर रही है तो यू आर गोइंग टू हैव अ लॉट ऑफ इन्फ्लेमेशन. माई डैड यूज टू टेल मी दैट आपको रोटी बनानी है, आप डॉक्टर हो चाहे कुछ भी हो, आप खुशी से रोटी बनाओ या दुख से रोटी बनाओ. तो मैंने क्या सोचा, रोटी नहीं बनाने का है, फॉरगेट अबाउट
Fasting.
Even in the lockdown period, I used to tell my daughter-in-law, you make very good rotis. You are the best roti maker, and she really makes very round rotis. So I used to tell her, I will do the atta for you, and you belo fry the roti. I will take out from the tawa, and we had excellent bonding. Now I want to tell one big point here. At our age or at any age, all of us can stop making rotis if you don't like it, but can replace it with some hobby that you like. Any art, because there is an artist in each one of us, and if we immerse ourselves in that art, we can become more happier and reduce the sympathetic overload, reduce the inflammation and the meta-inflammation
So
all over
the
the
other
body.
day, Dr. Shivram sir has given us a concept of brain relaxation and immersing experience, at least 10 minutes a day, is known to improve the stress levels and improve the BDNF, neuroplasticity. So I think that's what we've learned through this conference. For those who are new, one activity which is going to be immersing, and it's going to be an evolving experience done every day, is a brain preservation technique. So I think that is at least a simple take home from this conference. Yes, ma'am.
We are talking about increasing the protein intake. So out of 100 patients, how often are we able to avoid giving a protein powder? Can we manage the protein intake without giving a protein powder? How often can we
Diet.
manage? On diet, managing only on diet. How often is there a
Only on
protein
diet,
powder?
it's not possible practically.
Very difficult.
So
Non-vegetarian is possible.
it's not possible. रोज कहाँ खाएंगे मैडम? चिकन में एंटीबायोटिक, आर्सेनिक सब जाएगा मैडम.
I think, yeah, we need to work
Yes,
on
you
that.
want difficult.
I'm not a great
take
fan
veg
of
and non-veg.
supplements.
Okay, चलो non-veg है patient, तो हो सकता है, हो सकता है.
So 70-80 grams is doable. I mean, if you say 140 grams, I'm not sure. But 70, 80 grams with 2 eggs, chicken, enough
Paneer.
pulses, milk products, you will reach there. And some, I'm not saying no chapati. You have to have 2, 3 chapati or rice. That will also give you 6 to 8 grams.
No, and one
So
again point to
difficult
this.
for vegetarians.
Yes.
For vegetarians, it is difficult through diet alone.
And even for the people who are vegetarian or non-vegetarian, there is a concept of protein assimilation. So I may just drink tons and tons of protein. Doesn't mean that my body is going to assimilate that. So there is an important role of gut microbiome and the intestinal barrier and your intestinal absorption, the amino acid metabolism. So otherwise, everybody who would have taken protein powders would be like Hercules. You understand? It's not happening. So they still continue to have sarcopenia. So you need a lot of assimilation things when you are giving protein supplements.
There's a concept of anabolic resistance also, along just like insulin resistance. So after certain age, you need much higher protein concentration in the diet. Otherwise, you may not gain any muscle. When the same kind of protein intake or half protein intake, a younger person would develop muscles very well. So there is a pathway called mTOR pathway that gets activated by protein intake that can reduce the lifespan, really speaking, in younger people. But beyond 50, increment in the protein would be good. Below 50, we have to be cautious.
I would like to call up Vaishali ma'am for that.
Animal ला protein inject नाही करत मॅडम. Right, that's estrogen basically. So that is the, actually we talk about calories. What is a calorie? That is amount of energy required to increase water temperature by 1 degree Celsius. It has got nothing to do with our diets, but we just talk about calories. It is the proof that without caloric intake, an animal or a bird can increase weight tremendously. So just estrogen injection, minimum amount of caloric intake, the bird becomes 3 times in the weight, because that's helpful for the poultry person. So the hormones actually do regulate everything. And it gets partially destroyed in the cooking, but it remains in the non-vegetarian food, as what happens is antibiotics and arsenic and everything. So that becomes a trouble in too much of a non-vegetarian intake. So those things do matter. And why madam said perimenopausal phase, why ladies put on, that's the hormonal interplay per se. Though calories in, calories out, hypothesis is out because of that. We don't talk about it openly. We endos know it's all gone. Calories किती घेतल्या आणि किती झाल्या, that is not there. It's a measure to increase the water temperature by 1 degree centigrade. Nothing to do with our diet. So calories just, vague kind of a concept we are still sticking to, because there is nothing else right now.
Thank you all. Now I would like to call up Vaishali ma'am to felicitate our speaker. First, Sujit sir.